Adverse effects of blood transfusion. So a transfusion reaction is any adverse event related to the transfusion of whole blood, blood components, or human-derived plasma products. These can occur during or after the transfusion. So some classifications of transfusion reactions is timing-based, which is an acute transfusion reaction that occurs within 24 hours of transfusion. You can also have a delayed transfusion reaction, which occurs after 24 hours and can occur sometimes as late as days or weeks later. Then we can have immune versus non-immune. So the immune-mediated, this results from the recipient's immune system reacting to antigens in the transfused blood. Non-immune is caused by physical or chemical factors. Then we have infectious versus non-infectious. So infectious reactions is transfusion-transmitted infections such as HIV, hepatitis B or C, and syphilis. Non-infectious reactions, so the most common includes febrile non-hemolytic transfusion reactions, allergic reactions, trolley, and taco, and we'll talk about these later. For risk of transfusion, so transfusion reactions vary in severity, ranging from mild symptoms to life-threatening complications. Some reactions can lead to increased morbidity, which means they can have a prolonged hospital stay or organ damage, or even mortality, so in rare cases, but in serious cases, such as acute hemolytic or even during trolley. Preventable reactions, so most commonly due to clerical errors, such as mislabeling samples and or transfusing incompatible units. Can often be avoided with strict adherence to these protocols and double-checking identification. Non-preventable reactions occur despite proper technique and precautions. Some examples can be like an allergic reaction, febrile non-hemolytic transfusion reactions, and some delayed immune responses. There is a team-based response, so managing a transfusion reaction is a multidisciplinary responsibility that involves nurses. They're usually the first ones to recognize any signs and symptoms, the physicians who will direct treatment and stop the transfusion, the laboratory team who will perform post-transfusion testing, and blood bank personnel who will investigate product compatibility and trace potential errors. For regulatory oversight, so FDA, Center for Biologics Evaluation and Research, they are responsible for investigating all reported transfusion-related fatalities in the United States. This helps to ensure blood products meet safety, purity, and potency standards. It requires reporting of serious transfusion reactions, especially those that are fatal or life-threatening. For surveillance criteria, this is developed by the CDC and the NHSN, which is the National Healthcare Safety Network. It provides standardized definitions and reporting protocols for transfusion reactions. It can help improve detection, comparison, and response across healthcare systems. Some reportable transfusion reactions would be trolley, which is transfusion-related acute lung injury. This is life-threatening, non-cardiogenic pulmonary edema. It typically presents within 6 hours of transfusion, and it's strongly associated with donor anti-leukocyte antibodies. Then we have TACO, which is transfusion-associated circulatory overload. So there's a volume overload that causes hypertension, dyspnea, and pulmonary edema. This is more common in the elderly, pediatric, or cardiac compromised patients. And the prevention includes slower infusion rate and diuretic support. And then we have transfusion-transmitted bacterial infections. This is primarily a risk with platelet transfusions because they're stored at room temp. Some symptoms these patients may have are fever, chills, hypotension, and sepsis. So we would do a bacterial culture and gram stain of the product during the investigation to try to figure out what is causing this. All right, so the technical workup of a suspected transfusion reaction. So we have the initial technical evaluation. The goal is to rule out a hemolytic transfusion reaction, which could be life-threatening. This is usually conducted by transfusion service technical staff immediately after notification. So that first initial step is the visual inspection of the post-transfusion plasma for any hemolysis. So is it pink or red, that discoloration. We're also going to look at the blood bag for clots or discoloration. For clerical check, we're going to ensure proper patient-to-unit identification. We're also going to do a direct antiglobulin test, or a DAT Coombs test. So if it's positive, it may suggest an immune-mediated hemolysis. We're going to repeat the ABO and RH typing on the post-transfusion specimen. So the interpretation of the initial workup, if hemolysis is confirmed, we're going to treat it as an acute hemolytic transfusion reaction. If no hemolysis is observed, we're going to consider other causes of the reaction. For secondary testing, it's going to be ordered by the transfusion service physician. It's going to be based on the patient's signs and symptoms and clinical evolution of the reaction. This could include cultures if the patient is febrile or sepsis is suspected. They may do a chest x-ray if they are thinking that it's possibly taco or trolley. They could do a serologic antibody workup as well if it's a delayed reaction that's suspected. And they can do a urinalysis to check for hemoglobin in the urine. A reaction where signs and symptoms present during or within 24 hours of a transfusion reaction. So most can be grouped according to the common etiology that gives similar presenting signs and symptoms, and we'll get to these soon. For transfusion reactions due to red blood cell antigens, you have non-ABO antibodies for transfusion, pregnancy, and transplantation, and then there's also immunologic responses to anti-D, K, and E. For acute hemolytic transfusion reactions, by definition, this is a serious transfusion reaction that involves rapid destruction or hemolysis of transfused red blood cells. This occurs during or within 24 hours of transfusion. The pathophysiology of acute hemolytic transfusion reactions, so antibody recognition. So the recipient's IgM or IgG antibodies recognize and bind to donor red blood cell antigens. Commonly, this is like an ABO antigen. This is typically a preformed antibody, making it a primary immune response. Then there is the formation of the immune complexes. So the antigen-antibody binding leads to the formation of immune complexes on the red blood cell surface. These immune complexes activate the classical complement pathway, which results in the membrane attack complex formation and intravascular hemolysis of donor red blood cells. And then there is the release of the inflammatory mediators. So complement activation triggers the release of vasoactive amines, which is like histamine or serotonin. It also can activate the cytokines and prostaglandins. These can cause fever, chills, hypotension, and vascular permeability. This will then activate the coagulation cascade. So tissue factor exposure and inflammatory cytokines can activate the coagulation cascade, potentially leading to disseminated intravascular coagulation, or DIC, and microvascular thrombosis. So the effect of complement activation in acute hemolytic transfusion reaction is we have the membrane attack complex. So the terminal or lytic arm of the complement cascade forms the MAC, which is the C5b through C9, on the surface of donor red cells. So the results of the MAC formation is we have intravascular hemolysis. So MAC disrupts the red blood cell membrane, which leads to cell lysis within blood vessels. Can also have hemoglobinemia, which is free hemoglobin, which is released into the plasma. This gives the plasma that pink to red tinge. Hemoglobinuria, which is excess plasma hemoglobin, which is filtered by the kidneys, and this can show up in the urine. This can cause red or dark colored urine, which is often mistaken for blood. Some clinical hallmarks of intravascular hemolysis is they can have sudden fever or chills, hypotension, back or flank pain, dyspnea, hemoglobinemia, and hemoglobinuria. Steps when an acute hemolytic transfusion reaction is suspected. So some immediate actions is we need to stop that transfusion immediately. We need to perform a clerical verification to ensure correct patient and blood product, and then we need to notify the patient's physician immediately. So this is usually on the nursing side. But you never know where you're going to be at. So notification and then documentation. So we're going to follow the required protocols for reporting and documenting the reaction. And then sample collection. So we're going to collect necessary blood and urine samples from the patient for testing. And then we're going to gather our materials. We're going to collect that blood component bag and associated documentation for evaluation and further root cause analysis. For post-reaction blood sample handling, so if the post-reaction blood sample appears to be hemolyzed, we're going to request a second sample to confirm the presence of hemolysis, and not that it was just from the draw, that it's actually hemolyzed in the body. We're going to do potentially a direct antiglobulin test, or a DAT. So if the DAT on the post-reaction sample is newly positive or shows stronger positivity compared to the pre-reaction DAT, further workup is going to be required. So it'll require samples and testing. Timeframes for collecting and testing indicators affected by intravascular hemolysis must be followed to ensure accurate diagnosis. For a delayed serologic or hemolytic transfusion reaction, this is usually detected after 24 hours of transfusion. The cause, this is most commonly due to secondary amnestic immune response, and it can also occur during a primary immune response. So impact on transfused cells. This may cause delayed hemolytic transfusion reaction, which leads to a shortened survival of transfused red cells. This may also result in a delayed serologic transfusion reaction with no shortened survival of the transfused cells. So a common scenario in this is often detected when a new blood sample is tested during a typing cross-match request. Hemoglobin levels are lower than expected after transfusion. So timing, like mentioned, this is 7 to 10 days after transfusion, and clinical signs, they have unexplained anemia and evidence of hemolysis. So TRALI, or transfusion-related acute lung injury, by definition, this is an acute transfusion reaction presenting with respiratory distress and severe hypoxemia during or within 6 hours of transfusion. So an exclusion occurs in the absence of other recognized causes of acute lung injury. Additional symptoms can be accompanied by fever and or hypotension. Significance of this is it's considered the leading cause of transfusion-associated fatalities. So risk factors for TRALI. So patients with specific clinical diagnosis have an increased risk of developing TRALI, and these include patients who have a mechanical vent, have just underwent surgery, or had a massive transfusion. So the pathophysiology of TRALI, so it can cause damage to the endothelium, which leads to increased pulmonary capillary permeability, and this results in non-cardiogenic pulmonary edema. Then we have TACO, which is a transfusion-associated circulatory overload. This is an acute non-immune complication of transfusion, and it presents with respiratory distress and hypoxemia. Can occur during or after transfusion and can happen when the patient's cardiovascular system cannot handle additional workload. So it'll manifest as congestive heart failure. Some symptoms that are associated with TACO are respiratory distress, elevated blood pressure, fluid overload, and the other ones that are listed down there below on the table. For hypotensive transfusion reactions, in adults, this is defined as a drop in systolic blood pressure of greater than or equal to 30 millimeters of mercury and systolic blood pressure of less than or equal to 80 millimeters per mercury. For children, it's a 25% drop in baseline systolic blood pressure. Pathophysiology, this is just not well understood quite yet, but it may be related to an increased bradykinin levels in stored blood. For febrile non-hemolytic transfusion reaction, this is defined as an acute complication of transfusion. It can be characterized by greater than or equal to 1 degree Celsius increase in body temperature. It may be accompanied by chills, nausea, vomiting, tachycardia, increased blood pressure, and tachypnea. For allergic transfusion reactions, so this is an acute immune complication of transfusion. It can present with a variety of symptoms and reaction severity. It's caused by recipient antibodies responding to an allergen present in the transfused blood component. Graft versus host disease. This is a delayed immune transfusion reaction which is caused by immunologic attack by viable donor lymphocytes in the transfused blood component. These donor lymphocytes attack the transfusion recipient. For transfusion transmitted infections, so evidence of the pathogen must be found in the recipient. The recipient must not have had an infection with the same pathogen prior to transfusion. And pathogens must be demonstrated in at least one of the following: the transfused blood component, the donor at the time of the collection, or an additional component prepared from the same donation, or an additional recipient of a component from the same donation. For septic transfusion reaction, this is an acute non-immune transfusion reaction, presents with fever, usually with greater than 2 degrees Celsius increase in body temperature and rigors. Can be accompanied by hypotension and can be caused by transfusion of bacteria contaminated blood components.